Hello, good evening, everyone. The webinar will be starting shortly. I hope you can hear me now. Um, all right, so before we begin, please everyone mute your mics and let's so we can hear me while I speak and we can start the discussion. Um, I think we can go ahead and start. I hope you guys can see my screen. Okay. So today's lecture is on scleral lens fitting. And this is going to be an introduction because we are looking at different aspects of specialty contact lens fitting in this webinar series. So we're starting off with scleral lenses. This webinar is sponsored by Biosafety and brought to you through the iAfrica Media platform. Today, like I said, we're going to be talking about something that's very dear to me, something that I practice daily, something that I have seen change lives, including mine, and something that I hope to share with you, and I hope you can also incorporate into your practice. Like I said, I have a few disclosures. I'm a speaker for the BioLens Lab based in Morocco. Also, I'm a columnist for the Cornea Frontiers blog on iAfrica Media, which deals with all things cornea and anterior segment. So by way of definition, scleral lenses are rigid gas permeable contact lenses. They actually sit over the cornea. We're all used to fitting normal contact lenses where we place them on the eyes. And once we place these lenses on the eyes, we notice that the lenses sit directly on the cornea. Unlike a scleral lens, which when you place on the eyes, it actually vaults the cornea. So I'll take this animation again. Here we have an irregular cornea. You can see it's protruding at this point. We would say maybe that's keratoconus or some form of ectatic corneal disease. Now, when you place a scleral lens on the eye, you have this space between the lens and the cornea, so it doesn't touch the cornea. So that's what makes scleral lenses quite unique. One, they don't touch the cornea, so they're quite comfortable. And two, they can be fit in very irregular corneas and still improve vision. Now, scleral lenses are used for rehabilitation of very regular corneas, as I mentioned, including corneal transplantation, what we'll call post-graft corneas. And because of that unique feature of the space between the lens and the cornea, which is filled by saline, we'll talk about that as we go on, it can be used as a drug delivery system. It can also be used for ocular surface disease or in managing severe dry eyes. So let's look at the cross-section of what the scleral lens looks like. So here we have this gray arrow. This is the cornea. So this could be an irregular cornea. And here we have this highlighted fluid reservoir. It's highlighted because we've put fluorescein into the saline. So that highlights the space between the cornea and the lens. So this is the scleral lens. This is the fluid reservoir, and this is the cornea. Now, what is unique about this is this fluid reservoir is where all the magic happens, because this is what smoothing that irregular corneal surface and improves vision. This is what can be used as a drug delivery system. So you could put medications in this if you do not want to even put the normal saline that you would use. And this can also be used for severe dry eye patients, as we'll see as we go on. Now, there are several indications or reasons why we would want to fit contact scleral lenses. Number one is very ectatic corneas. For example, here you see in the images, you see these are all irregular corneas from the extreme right to on my screen. You can see a very advanced keratoconus, like a nipple cone. It's very steep and ectatic protrusion at the center. And here we see a pellucid marginal degeneration where we see sort of flattening of the corneal profile and then it becomes steeper on the inferior part. And here we see a keratoglobus where the cornea is bulging. Now, in all of these cases, we can actually fit scleral lenses and obtain good vision. After refractive surgery, sometimes patients experience corneal ectasia. That means the cornea becomes irregular, becomes thin. You have irregular astigmatism, which is not improving with spectacles. Scleral lenses have that unique property in improving vision in those patients. Like I mentioned at the beginning, they can also be used for patients who have ocular surface disease or severe dry eyes. And in this image, you can see here this patient has obvious limbal stem cell deficiency. You see the whorl-like epithelial pattern, you see the irregular and dry surface. Scleral lenses, because of that hydrating property, again, I'll go back to this image. Because of the fluid reservoir you have in the middle here, this enables you to hydrate the surface, lubricate the surface, and actually improve vision and give comfort in these patients. I have seen very life-changing experiences from patients, even from colleagues, where you have patients who come in with very irregular corneas who are unable to open the eyes just because of the severe dryness of the eyes, and no other contact lens or ocular surface disease treatment is able to give that immediate symptomatic relief. Now, once you put in the scleral lenses, because of that fluid reservoir between the lens and the cornea, hydrates the cornea, the patients are able to open the eyes, and it's been shown to actually heal the ocular surface. Aside from severe dry eye patients, it's also useful in patients who have Stevens-Johnson syndrome, filamentary keratitis, very chronic conjunctivitis that causes sloughing off of the corneal epithelium. Also in exposure keratopathy. Now, typically a patient with exposure keratopathy, you would maybe put a bandage lens in some cases, which may not be appropriate in all cases. In other cases, a tarsography would be done where you would apply a suture, where the surgeon would apply a suture to the lids to close the lids together. Now, what happens when you do this? Again, it becomes sometimes difficult to apply medications. Sometimes, obviously, the cosmetic appearance is not appealing. Whereas with a scleral lens, and this has been shown in studies, not just my clinical experience, there are studies that actually show that you could use scleral lenses in patients with exposure keratopathy. So what happens is you put preservative-free medications in this saline, and you put some saline or whatever medications you want to put in, and you place the lens on the eye, and you actually have improved vision, improved comfort, drug delivery, and protection of the ocular surface or the cornea from that exposure that the patient is experiencing. Now, aside from very irregular corneas or very dry ocular surfaces or very dry eyes, scleral lenses are also good for very high refractive errors, such as when you have patients with aphakia, high myopia, high hyperopia, discomfort with corneal GP lenses, when the patient has this habit of frequently losing their contact lenses, when they're actively participating in sports, or when the environment is dusty. You could use scleral lenses because the scleral lens sits very nicely on the ocular surface, barely moves. Again, would improve vision, gives very great comfort, and they're very, very comfortable, even as comfortable as a soft lens, if not even more comfortable in some cases. Now, at the beginning, I did mention you could fit scleral lenses in post-graft cornea. So say a patient has had corneal transplantation for keratoconus or some form of ectatic condition, or a corneal transplant, a penetrating corneal transplant, whether it's the penetrating keratoplasty, or if it is the deep anterior lamellar keratoplasty, DALK. Now, the thing is, once this procedure is done, in some cases, because of the suturing techniques applied, because the cornea does not align or conform to the contour that the original cornea had before, you have an irregular surface, irregular elevation, and that leads to decreased vision, which may not be correctable with glasses. However, when you fit scleral lenses in those kind of patients, you are actually able to improve their vision. Sometimes post-corneal tear repairs, when patients have corneal scars, like in this case, that leads to irregular astigmatism, scleral lenses are great. Now, one area of scleral lenses that I have actually enjoyed using is using them for patients who have post-trabeculectomy hypotony. Now, we know that when patients undergo trabeculectomy for glaucoma or glaucoma filtration surgery, sometimes they could have a bleb leak. Now, when the bleb leaks, the typical thing to do is to put a soft bandage contact lens, but to act as a tamponade. But sometimes that soft bandage contact lens is not enough. It doesn't put enough pressure as it should over the leaking area. Now, sometimes the surgeon may suture the area of leakage. Sometimes the surgeon may do pressure patching, but sometimes these options do not work. Now, what a scleral lens will do is, because of its large diameter, sit on that area of leakage and actually close the leakage and cause the pressures to form and the anterior chamber forms. And after that, you can discontinue scleral lens wear. I've been fortunate to be able to work closely with a glaucoma surgeon who's cross-referred patients to me, and we've managed a few cases with very good success with scleral lenses. Now, some of the advantages, I mean, I've already talked about some of them in the course of the presentation. Scleral lenses are very comfortable. They give very good vision quality. They can hydrate the cornea. They are very stable. They do not move like other forms of contact lenses, including corneal GP lenses, because if you fit, or if you've seen corneal patients who wear corneal GP lenses, sometimes they worry about that constant movement of the lens, and the increased awareness of the movement of the lens causes tearing, generally contact lens discomfort, and sometimes that may lead to dropout or decreased wearing time. But with scleral lenses, you do not have any of that. Like I said, they're very stable. You do not have any limitations in terms of how irregular you can fit. There are sagittal heights, so you can adjust whatever parameter that you need to adjust with scleral lenses, as we'll see as time goes on. And studies have actually shown it delays the need for corneal transplantation. Now, in patients who have undergone corneal transplantation for maybe keratoconus or whatever form of corneal irregularity. Now, we know that it's usually in the advanced cases that these procedures are done. However, with scleral lenses, you could actually fit very, very regular corneas. And by doing this, you delay the need for corneal transplantation. I mean, there's a study, I think this was published in Cornea Journal a couple of years ago, and it showed that about 86% of patients who were previously indicated for corneal transplantation no longer needed corneal transplantation after being fit with scleral lenses. That shows you, again, how much you can decrease the need for maybe needless surgeries, and also the cost you're saving the patient, the time you're saving the patient, and keeping in mind that corneal transplantation is it's a lifelong thing. It's not something that you're just going to do today and then everything is go happy tomorrow. So you have to monitor these patients. They have to be checked regularly. Sometimes the sutures get loose. Sometimes there's graft rejection. Sometimes the graft actually fails. If you can delay the need for any of these drama or episodes that the patient will go through, obviously you would want to fit a scleral lens and give the patient the best that they can get. Now, today we're going to be focusing on biosafety scleral lenses. And biosafety scleral lens is very unique scleral lens. It's very easy to fit. I mean, trust me, I have fit a lot of scleral lenses and different scleral lenses, and these are quite easy and quite straightforward to fit. And they have their different parts or different. Can we mute everyone? So we have the central zone, which is the central, which basically sorry, 1 minute. All right, so we have the central zone, which basically looks at the central part of the lens. And this is where you have the base curve of the lens. This is where you have the main power of the lens. This is where you have, in quotes, the treatment zone. Now, there are three other zones as we go on that we will see. We have the paracentral zone, we have the limbal zone, and we have the scleral zone. Just change this. Now, the good thing about biosafety scleral lenses is they are made from materials that are very, very oxygen permeable. We would say they're breathable lenses, they are gas permeable lenses, and they're top of the quality lenses. I mean, if you know anything about GP lenses, you know that Contact materials top of the top, and that's what's used in manufacturing these lenses. Now let's talk about the zones, as I talked about before. So we have the central zone. Now the central zone of the scleral lens is where you have the base curve, like I said, is where you have the power of the lens being fitting. And this is the part that will sit on the central portion, as you see highlighted in blue here. Now we go to the paracentral zone. Now this zone sits between the transition between the limbus and the central part of the cornea. We'll look at how we can modify these zones later as we go on. And then we have the limbal zone, which sits directly over the limbus. Now, this zone is very important and it plays a very big role, not just in fitting of the lens, but also the lens physiology and how it interacts with the ocular surface and the overall success of the lens in general. Because while you're improving vision with scleral lenses, you do not want to do any harm to the cornea. So remember, the first rule is it must not touch the cornea. I just quickly scoot back to the image. Yeah. So that reminds you of what the scleral lens should look like on the eyes. You have the cornea, you have the fluid reservoir, and you have the scleral lens. So you do not want scleral lens to touch the cornea at any point. So we go back to the fitting parts of it. Now we have the last zone, which is the scleral zone. Now this sits on the scleral lens. Keep in mind, the scleral lens, as you can see in this image, never touches the cornea. It vaults the cornea, vaults the paracentral cornea, vaults the limbus, and only makes touch or makes landing with the sclera, actually. Now, this is very important because you do not want any tissues to be compressed or damaged in the course of the fitting of the lenses. Now let's look at the scleral zone and how this can be modified. Now the scleral zone can be spherical, it can be toric in the front surface. So you might have patients who have very, very regular corneas and the over-refraction or the refraction coming out even after fitting the lenses are toric. You can fit toric prescriptions on scleral lenses as well. Now, you need to keep in mind that when we fit scleral lenses, we do not pay so much attention to the base curve in selecting the lenses. We'll talk about this as we go on. Now, we would mostly talk about the sagittal height. Now, this means how high is the lens. So that would be, for example, if I place a scleral lens on a surface. Now, if this is a flat surface, as you can see in the image, the distance between the, if we take a flat reference point to the highest point or the peak of the scleral lens, we refer to that roughly as the sagittal height of the lens. We want to talk about how high is this lens, because most times, let's face it, we fit scleral lenses for patients who have keratoconus. So you have a patient who has a very, very, very irregular cornea, very steep or very ectatic cornea, and you want to see how high can you go over that hill of the cornea without touching or without compressing the cornea and still give good vision and comfort. Now, the central zone of the lens is adjustable in microns, about 100 microns. So you can go 100 microns higher, 200 microns higher, 300 microns higher, 100 microns lower as well, depending on how you would like to adjust the fit of the lens. So you go higher, like you see in this image, you could go lower. Now, generally, we want that distance between the central part of the cornea and the scleral lens to be about, say, between 250 to 400 microns. We do not want it to exceed that, because if it exceeds 400 microns, studies show that you could actually induce corneal edema because of hypoxic changes to the cornea, because the oxygen has to travel through the scleral lens, through the fluid reservoir before getting to the cornea. So you may induce corneal edema if you fit a scleral lens in the central too high. Now, the paracentral zone, we would usually adjust when we have a touch in the paracentral area. Now, sometimes you may have irregular corneas where the most ectatic point of the cornea, or the point that bulges more on the cornea, is actually not the center. There are cases of inferior keratoconus, there are cases of superior keratoconus, there are cases of pellucidal corneal degeneration. Now, these are conditions where the irregular point or the most ectatic point on the cornea is not in the center. In those kind of cases, you may fit a scleral lens and it looks great in the center, but in the paracentral area or in the mid-periphery, it is touching. Remember the first rule, we do not want it to touch any part of the cornea. Now you can adjust the paracentral zone also in microns, go 50 micron step. So with the safety scleral lens, you could just specify when you're ordering the lens, PZ plus 1, PZ plus 2, PZ plus 3. Now the lab already knows if you plus 1, you're just adding 50 microns to the paracentral zone. And this can go on for different clearance that you want. As you can see, as I move from P0 to P plus 1 or P0 back again, you see the change in the paracentral zone. So you can actually customize whatever area that you want lens, even take it in if you need to. And this may be important for corneal transplants or post grafts because the graft host junction of the cornea tends to be sort of proud. It sits up a bit. Now, in a corneal transplant, you have the graft, which is at the center. You have the host cornea, the patient's original cornea, which is in the periphery. The point where they meet is what we call the graft host junction. Now, that area tends to swell more, tends to be more ectatic, tends to bulge out more. Now, what you do not want to do is injure that area with your scleral lens. So that's where it's important to adjust the paracentral zone if you're fitting post-graft. Limbal zone, like I said at the beginning, is very important because keep in mind, aside from the limbus being sort of the vascularized transition zone of the cornea, it also houses stem cells, which help in the replenishing of the epithelium of the cornea. Now, if you fit a scleral lens that compresses on that limbal zone, you could induce limbal stem cell deficiency. You could decrease the replenishing of the corneal epithelium, and that will cause epithelial sloughing, that will cause recurrent corneal erosions, discomfort, dry eye disease, and things like that. Now, this could happen with any other form of contact lens if it actually insults the limbus. However, with the biosafety scleral lens, you can actually adjust that zone independent of the other zones and also do so in 50 micron steps so that you are improving the patient's vision and not harming any other ocular surface tissues. Now you could go from L+1 to as +6. Now this is in 50 micron steps. And if you see in the image, as I change, you see the change in the limbal zone as well. Now the landing zone, which is the last part of the scleral lens. Now this part sits directly on the spongy conjunctiva. Remember, we have the conjunctiva on top and we have the sclera underneath it. Now, it may make you wonder why we don't call it conjunctival lens, but yeah, it sits on the conjunctival tissue with the sclera on top, but we still name it the scleral zone or the landing zone. Now, this part is adjustable in 25 micron steps. Now, each of these zones I've talked about, we're going to see examples when they need to be adjusted after we go through the fitting process of the scleral lens. Now, the good thing about biosafety lenses is you could have trial lenses sent to you. You just have to order from the lab. And I mean, you could reach out to us and we could get you set up with a fitting set and teach you how to use this set. I mean, attending this webinar is one step, and that helps you know how to actually fit these lenses. Now, there are trial sets available. Like I said, all the 4 zones of the lenses, they are all adjustable. They have very high decay materials, which would allow oxygen pass through the lens. They are breathable, and you have less chances of inducing hypoxic changes. Now, these lenses are plasma treated, so which means the surface coating or the surface wettability on the lenses is very great. If you want to take it a step further, the lenses could undergo something called hydropolyethylene glycol treatment. So what this does is it creates a smooth, slippery surface over the lens. Now, this is important, especially for patients who have ocular surface disease. Maybe you're fitting the lenses for Steven-Johnson syndrome or dry eye disease. And we know that these patients tend to have a lot of discharge, a lot of mucus, protein deposits, which can accumulate on the lens surface. But because you have fitted it with the Hydra peg, the surface is quite slippery and those deposits do not attach, and that does not give the patient any discomfort. Like I said earlier, they are available in toric options. It could be in the haptic, in the scleral, it could be toric because let's face it, we've all thought that only the cornea can be toric. I mean, when we were back in school, when you're being taught about astigmatism and you're being taught about difference in the elevation of the cornea or difference in the depression of the cornea, I think that that only happens on the cornea. But that irregularity can extend towards the sclera as well, especially when you go 15 millimeters away from the central part of the cornea. The sclera becomes quite toric, and there are actually machines that can actually map out the toricity of the sclera. They're called scleral topographers, just the way you have a corneal topographer. Now, when you have an irregular scleral surface and you fit a scleral lens on that irregular surface, what ends up happening is you have the eyes, the lens is not maybe fitting properly, not aligning to the ocular surface properly. We'll see examples as we go on. But with these biosafety lenses, you can adjust and make the periphery of the lens toric. so that it locks in with the regular cornea or the regular scleral surface and is well centered and gives very good vision. And again, the prices are quite competitive. I know I've talked a lot about scleral lenses. I've just given a brief introduction. We'll just take a break and through the profile of what BioLens has to offer. And after the break, we'll go down into the fitting proper. So let's just listen. And after
BioLens Lab was founded in 2013 by professionals in the fields of optics, contactology, and contact lens manufacturing. Based in industrial zone of Mohammedia, we are custom contact lens manufacturer specialists. New building with a modern laboratory built in 2019, specially designed to meet the international quality standards required and to accommodate new technology and growth. Provide the needs of visual health professionals, and through them, all patients requiring a visual or ocular surface rehabilitation with contact lenses. Provide more solutions in the fitting of contact lenses, especially for the most difficult cases. Improve the quality of life of patients. In our industry, technology moves quickly. We invest strongly in the latest technology. By installing the most modern CNC lathing of DAC International from USA, machines offering indeed the very innovative products with the most complex design with supra-nanometers precision. We have chosen the latest American plasma cleaning technology for the surface treatment of our contact lenses. The highest manufacturing standards. BioLens Lab is ISO 13485 certified company. We apply the good manufacturing practices, GMP, required in our field. We are registered manufacturer in Morocco, and our products have registration certificate from Ministry of Health. For the raw material, we have chosen the best, Contramac. Our raw material supplier is one of the world leaders in the field. Our custom contact lenses are the first choice of advanced fitters in Morocco, interested in personalizing patient eye care. We manufacture RGP contact lens, Scleral lenses, Ortho-K lenses, soft contact lenses in hydrogel and silicone hydrogel, cosmetic contact lenses, prosthetic contact lenses. Provide ongoing technical and clinical support for our product line. Support fitters in their practice to achieve successful contact lens fitting. BioLens Lab organizes training seminars for professionals. Participate and sponsor scientific events. Organizes training workshops at the BioLens Learning Center. Training webinar. BioLens Lab improve the quality of life of patients.
All right, so that was a quick message from BioLens Labs, the sponsors of today's webinar. So now we go down to the interesting part of the webinar rather, which will be the fitting of the lenses. How do we fit scleral lenses? We've talked about why we should fit scleral lenses, when scleral lenses are indicated, what conditions we can use. We've seen a cross section of what the scleral lens design looks like. So now we go to fitting the lenses. Like I said, you have the biosafety scleral lens fitting set. Now, this is very particular, very important for an area such as Africa, because you want to try these lenses on the patients. Well, you can fit empirical lenses with certain designs or softwares and things like that. But at the end of the day, you want to try these lenses on the patients. And I tell you, the change or the improvement that you see is not only in the vision of the patient. I mean, for those who maybe have worked with me or have fit some form of scleral lenses or specialty lenses for patients who have keratoconus, the improvement is always dramatic. You have a patient who maybe has seen 5, 6 doctors before they get to you. They may have even had corneal transplantation, collagen cross-linking, intrastromal corneal ring segments, and still the vision is not improving. But you just throw good fit scleral lens in the eye and the vision goes, the improvement is wow. I mean, I once had a patient say he could see his pores on his skin where his hair came from. And that's something that we all take for granted every day. That's something that we probably do not think even matters. But at the end of the day, it's really life-changing to see how these lenses improve the vision in patients and also gives very good comfort, especially with patients with severe ocular surface disease. Now, the lenses are marked and given codes based on their diameters. And also they come in different powers and different sagittal heights. We'll talk about the sagittal height and how to select that as we go on. Here are the 3 things that you want to keep in mind when you're starting to fit the scleral lens, when you want to select the scleral lens. We'll start off with the diameter. Then we look at the sagittal height, and then you can think about the material later as you go on. Now, the material usually for these lenses, for biosafety lenses, they're not something that you actually have to worry about because you're fitting lenses that are using the highest quality of materials out there, and you actually do not need to even bother yourself with the oxygen transmissibility because contact materials are very, very good, very well known for excellent oxygen transmissibility through the lenses. Now, what you would need to start off, again, the scleral lens fitting set comes with the plungers. So we have the big plunger, which is for inserting the lens. We have the small plunger for removing the lens. We have preservative-free saline. Now, they have to be preservative-free because the saline is going to be sitting against the cornea throughout the period this patient is wearing the lenses. Now, there are studies that have actually shown and also have been some studies we've also conducted at our center has shown that the swelling change in corneal thickness that occurs when you fit scleral lenses does not amount to clinically significant corneal edema, which will be 4% when a patient sleeps. So if a patient goes to bed and they sleep, generally, whether you're wearing a contact lens or not, without a contact lens, that is, you go to bed and you sleep at night, the cornea swells a bit by about 4%. And studies have shown that scleral lenses do not even induce up to 4% corneal edema when you follow the fitting guides. So you would need a preservative-free saline so that you're not causing any toxicity with preservative stain against the cornea, the insertion and removal plungers, and fluorescein. Now, fluorescein is not compulsory, advised because it helps you visualize the fluid reservoir better. Obviously, you need a slit lamp so that you're able to examine the lens on the eye of the patient. Now, the first thing is to select the diameter of the lens you're going to fit. Now, there's a formula where you say the horizontal visible iris diameter plus the limbal width on each side, because the right and left, the side of the, or the nasal side of the limbus and the temporal side of the limbus, or you could just say the limbal width times 2, the landing zone width times 2, and add that to the peripheral zone width times 2. Now, this is a long formula, and you're going to have to be doing a lot of micro measurements, but BioLens has simplified this for you. If the HVID is less than 11.8 millimeters, it fits the 15.1 lens. If the HVID is greater than 11.8 millimeters, you fit the 16.3 diameter lens. Easy peasy. You don't have to use that complicated formula I talked about in the beginning. Also, you need to pay attention to the eyelid opening because sometimes when we fit scleral lenses, we may be fitting in an eye that has already had maybe a lateral tarsography. So if the patient has had a lateral tarsography, for example, the palpebral fissure or the opening of the eye is not so wide. So you may not be able to get a large diameter lens into the eye. So we may go for a smaller diameter. Same with patients who have maybe small palpebral fissures normally. It may be impractical to actually force the eyes very wide open to fit a very large diameter lens, especially, for example, if the patient is from an Asian origin, where they tend to have small elongated palpebral fissures, you may not be able to fit large diameter lens. So you need to take that into consideration. Also, the handling. It's easier to actually handle small, we'll say mini scleral, although the Scleral Lens Education Society now recommends we just call them scleral lenses instead of having demarcation, say mini scleral versus full scleral lens. But the smaller the diameter of the lens, the easier it is to handle by the patient. And then can we all mute our mics, please? And then the scleral toricity. Now, when the surface of the sclera is very irregular, some studies have shown you can actually fit a smaller diameter scleral lens to avoid the irregular scleral profile. If you have to fit a large diameter or a scleral lens that will cause significant scleral toricity, the lens still has you covered because you can actually fit a toric periphery scleral lens that can actually align. But the key takeaway from this slide should be select your diameter based on the horizontal visible iris diameter of the cornea. And if it's less than 11.8, go with the 15.1 lens. If it's larger than 11.8, go with the 16.3 lens. Now, the next thing we'll be looking at is the sagittal height of the lens. Now, we have a lens that has, when we fit contact lens,
I've been waiting. Oh no,
when we fit contact lenses, we generally would think of selecting the base curve of the lens. We would generally think of what is the base curve I'm going to select. Like I said at the beginning, we do not really do that with scleral lenses.
Congratulations. This is fire.
I'll just mute that person.
A girl in an Audi.
All right, sorry about that. So like I said, if it's scleral lenses, we're looking at the sagittal height of the lens. Now, we're not paying particular attention to the base curve of the lens because when we think of, if I say select a contact lens to fit an eye, I think the first thing anybody would be what base curve do you select? But with scleral lenses, we do not start off with selecting the base curve of the lens. Instead, we look at the sagittal height. Now, you could get the sagittal height of the cornea from a corneal topographer. So what your corneal topographer would do is give you the sagittal height at what we'll call a particular chord of the cornea. Think of it as the diameter of the cornea, typically on the 15 millimeters chord. So let's say the corneal topographer gives you a corneal sag of say 4,000 microns, for example, and remember, you do not want to fit exactly on the cornea because it will touch the cornea. You want it higher than the cornea because higher than the cornea,
because of
actually,
people.
Exactly.
When it's your time.
So if it's higher than the cornea, you would actually be able to vault over the cornea and not have the lens touch the cornea. So what we want to do is add a couple of microns to that. So let's say we add 400 microns to what we get at 15 millimeters chord. But keep in mind, scleral lenses actually do settle. So when you fit a scleral lens, the conjunctiva, like I said, is spongy, it's soft. So when you fit a scleral lens initially, the position that it is not the same position it will be later on. It generally sinks, and research shows and also clinical experience shows that this sinking can continue for up to 8 hours. But the first 50% of the sinking happens within the first 1 hour of inserting the lens. So it gives you a rough idea of where the lens is going to be. If you do not have a corneal topographer, you could still fit scleral lenses. If you have a biometer, for example, where you can measure the anterior chamber depth, we would say measure the anterior chamber depth, add 500 microns to that. That will give you a lens that you could start off with. Just give me a minute. All right, sorry about that. The last part is the empirical fitting. Now, with some modern topographers, you may be able to just measure the entire ocular surface profile and send that to the lab. Even your corneal topography, you could do that and send that to the lab. And by would actually design a fitting scleral lens for you and send you the lens and then to try it on the patient. But we highly recommend fitting with the fitting guide, fitting with the trial sets, because then you see that life-changing experience and you can actually see the vision improvement and whatever adjustments are required to be made, you can see those live. Now, we've talked about selecting the sagittal height. We've talked about selecting the diameter of the lens. Once you've decided what you want to do, what diameter you want to fit, what sagittal height you want to fit, you pick that from your set and then you place on the eyes. Assuming you do not have a topographer, you do not have a biometer, you do not have a corneal topographer or a scleral topographer that can map out all the parameters, including the elevation of the cornea or the corneal sagittal height that you can send to the lab, you can still fit scleral lenses. All you have to do is take a lens from the trial set, go mid. What I usually would do, I mean, this is how I was trained initially before we started using modern gadgets. Take your slit lamp and look at the cornea profile. You could sweep that from the periphery, from the nasal part to the temporal part, and look exactly at how the cornea profile fits. And you'll be able to see that when you look at the corneal profile, it gives you an estimate or an idea of how bulgy or not the cornea is. And we often recommend start with an average sagittal height, 4,600 microns, that on the eyes, and you would know to increase or decrease or go from there, as we will see in this example. Now, a successful scleral lens should not touch the cornea. Like I said, I mean, I keep saying this over and over again. You want to place the lens on the eyes and you want the fluid reservoir thickness after it has settled for about 4 to 8 hours. Typically, I will keep my patients with scleral lenses for 2 to 4 hours. Some people keep the patients for full 8 hours to see how the lens settles. Now, at the beginning, I usually would advise that you observe that optic section with your slit lamp. I'm just going to scoot over and go back to the initial slide. Yeah, so this is very important. So make an optic section with your slit lamp, put it at about 45 to 60 degrees. You could actually move the observation arm of the slit lamp and tilt yourself as if you're going to actually do specular reflection on the slit lamp. Now, this gives you a profile of the cornea. You see an optic section of the cornea, a very thin, nice slice of it. And you can see the cornea, you can see the fluid reservoir, and you can see the scleral lens all in one slice. Keep in mind, you've put the saline in the lens and you've stained it with fluorescein before applying it to the eyes. Now, once you've done this and you've placed it on the eyes, it helps you see what adjustment needs to be made. Now, if you are fortunate to have an anterior segment OCT, I'm fortunate to have that in my practice. So what we do is after we fit the scleral lens on the eyes and we've looked at the profile on the slit lamp, like I showed you with the optic section, you can actually use the anterior segment OCT and measure that fluid reservoir thickness so that you're very, very exact. Now, this is very important if you're involved in scleral lens research like I am, but if you're not involved in scleral lens research, and you just want to fit these patients and give them good vision and improve their quality of life, which is why we're all here at the end of the day, you could do that still without using an anterior segment OCT. All you have to do is have your slit lamp, move that optic section from the nasal to the temporal side, and make sure you're seeing any touch at the central portion, at the limbal portion, and you're seeing that the scleral lens just sits nicely on the ocular surface without compressing it. If you see this image here, you see that none of the blood vessels that sits on the conjunctiva where the scleral lens is actually sitting is being compressed. Now, the good thing about this is this will give good comfort, that wow improvement in vision. Now, you want to switch to your cobalt blue light so you can observe. I'll just zoom my screen so that you can see this image here. So you want to see this diffuse spread of fluorescein underneath the lens. Now, what this shows is there is no touch. Now, sometimes you may see a very thin area of fluorescein, or it almost looks like there's no fluorescein. What studies show is that there has to be at least 25 microns of fluorescein underneath the lens for the human eye to be able to detect it. So sometimes if you cannot detect it, it may not mean that there is no fluorescein in that area. Okay, now once you've filled the lens with saline, preservative-free saline, obviously. You stain with fluorescein and you apply the lens to the lens. There are different application techniques. You could use the plunger, like in this image. Excuse me. Like in the image here, you could use the plunger. You could also use the hand. I usually do not recommend the hand technique unless you become a pro at fitting scleral lenses. But if you have learned that technique, the three finger technique, that's absolutely great. You can do that as well. Also, once you've placed the lens on the eyes, you want to observe that there is no air bubble. Now, this is very important because if you do not fill enough saline into the lens, you could have some of the saline pour out when you're trying to insert it, especially at the beginning, which is absolutely fine. But when you have air bubbles trapped underneath, you want to take out the lens and then refill it and put it back in, because if you do not do that and you have air bubbles trapped against the cornea for a long time, it will cause desiccation in that area, epithelial punctation, and that can cause discomfort when you take off the lens. Now, once you've placed the lens on the eyes, you want to check the size of the lens to see that it's vaulting the cornea. It's not touching the cornea at any point. The central fluid reservoir is adequate. The limbal fluid reservoir thickness is adequate. Now, what we will consider adequate at the central would be between 100 to 250 microns of distance after the lens has settled. Now, it may be tricky if you do not have an anterior segment OCT to do this, but I'll teach you a trick that I often use. Again, I keep going back to that image at the beginning, but I think it's very, very important, and it's an image that I like a lot. Now, if you know the thickness of the lens, so I'm just trying to get my cursor proving stubborn. Okay. Great. So if you know the thickness of the scleral lens, I mean, we would generally not want to use the thickness of the cornea because you could be fitting a patient with very thin corneas like in keratoconus globus and the cornea is tactic. That might not be a good reference because you might not know the thickness of the at all points. But your lab will often, I mean, biosafety as well. Biosafety will always provide you with the thickness of the scleral lens. So you could use that as a reference point. So let's say we have the thickness of a scleral lens of, say, 300 microns. Now, if the scleral lens is 300 microns thick, now look at the fluid reservoir underneath it, which is highlighted with fluorescein, and you make a mental image or mental estimate in your mind. Am I seeing twice of the scleral lens thickness? Am I seeing half of the scleral lens thickness? If I'm seeing twice of it, it means I'm looking at something that's approximately 600 microns. If I'm seeing half of it, I'm looking at something that's approximately 150 microns, because keep in mind, if your scleral lens is 300 microns, half of that will be 150 microns, and twice of that will be 600 microns. Keep in mind, we do not want to exceed 400 microns when we insert the lens at the initial time. And when it settles, we want it to be between 100 and 250 microns. So this gives you an idea. Same thing applies for the limbs. We do not want the limbal clearance to go beyond 100 microns because at the end of the day, this would lead to other complications or other problems as time goes on. Now, I talked about bubbles. Now, in the event of the bubble, you have to move the lens. But not all bubbles will occur when you insert the lens. Sometimes you have the bubbles occurring just after the lens has been inserted. I mean, you fit the lens, everything looks great, and then you take the patient to the microscope and you look at the fluorescein pattern and it looks smooth and even and lovely like this. And then suddenly you start seeing small bubbles trickling. Usually that's an indication of the periphery of the lens not being adequate. The periphery of the lens on the scleral zone not aligning properly to the scleral profile means you have a toric sclera. We'll talk about how to detect that later and how to switch to a toric periphery scleral lens. Now, when you've put the lens on the eye, I talked about having the central fluid reservoir, the central clearance between 100 microns to 250 microns when the lens settles. But if you fit maybe a lens on a cornea that's very proud or a very ectatic cornea, you could have a lens touch. So what this indicates is the lens sagittal height is too low. Increase the sagittal height, make the lens higher. If the lens sits higher, it will not touch the cornea because remember, number one rule of scleral lenses, no cornea or limbal touch. Now, if you have excessive clearance, that too can be a problem. But this is what you want at the end of the day, a smooth, even fluid reservoir thickness all around. Now, this you can assess on the slit lamp even if you do not have an OCT. Again, I keep saying I love this image so much because you can actually see the cornea, the fluid reservoir, and the scleral lens. Use the scleral lens thickness as a reference. If this is 300 microns, if you actually look at this image, they almost look similar. This is maybe slightly thicker. So I would say if this scleral lens is 300 microns, this is approximately 300 microns or maybe at most 400 microns. But that gives you a mental image and you know whether to slightly decrease the fluid reservoir thickness by decreasing the sagittal height, increasing it by increasing the sagittal height if it is needed when you have a touch, like in this image here. Now, if you want to take it a step further, do it with your anterior segment OCT and you would get exact value measurements. But remember, you do not want to do this too soon. Like I said, scleral lenses sit on the spongy conjunctiva and they tend to sink over time. And that settling or that sinking can go on for as long as 8 hours. But 50% of it happens within the first 1 hour. So you want to see your patient immediately you've applied the lens to the eyes. Let them sit in the waiting room while you see other patients and do other things, and call them back after an hour. Do that optic section again and see how much the lens has sunk to the ocular surface and see the distance. Because at the end of the day, when the lens settles, you do not want that fluid reservoir thickness to be more than if you don't want it to be more than 400 microns at the end of the day. But what's recommended is between 100 to 250 microns. Now, sometimes you could have excessive apical clearance or excessive fluid reservoir thickness. The problem with this is, I mean, the fit might look well centered and everything is great, but you start to have these debris that sit underneath the lens. Now, this has been a debate for years in the scleral lens research community, what these debris are. Studies actually show that some of them are actually inflammatory cells, macrophages, polymorphic nucleocytes, and all that stuff sitting underneath the lens, which could mean that when you fit scleral lenses too high fluid reservoir, you induce hypoxia, which causes pro-inflammatory environment and the cornea starts to react in a certain way. It could also be that because you have caused such a huge space between the scleral lens and the ocular surface, you have debris floating from different areas. Now, sometimes we describe this as midday fogging. So the patient has put the lens, the fluid reservoir is clear at the beginning, and then you call the patient maybe after 2-3 hours and you're seeing that the vision has gone down a bit. The patient is complaining that everywhere looks cloudy. You may have fit the lens with apical clearance, central fluid reservoir thickness too high, like you see in this image. I mean, if we estimate that this is a 300 micron scleral lens, imagine what this fluid reservoir thickness is. This is probably looking at 5 or 6 times what you have there. And obviously, this would not be a good fit. This is, as you can see, it's cloudy there. Now, you could also have a situation where you have fit the lens and it's so close to the cornea. The problem with when this happens is you could see the lens is sitting really close to the cornea. And when you look at the cornea with a diffuse cobalt blue filter, you sort of see like almost no fluorescein in the center. Now, when this lens settles, it could actually compress the cornea and you will see staining in that area. And that could cause decrease in vision, alter the corneal curvature, and this is obviously not good, so that's bad. What you want at the end of the day is insert the lens. The fluid reservoir thickness is between 250 to 400 microns at the initial time. And then after the lens settled, it goes down to about 100 to 250 microns at the end of the day. Similar in the central zone, like we talked about, you have a patient who has maybe marginal degeneration or a post-corneal transplant case, like you can see in this image here. Now, if you see, this is the graft-host junction, as you can see on this image here. Now, the graft-host junction is usually the proudest area of the cornea where you have the graft at the center, the host at the periphery, and they meet at a particular point. We call that the junction. Now, you see that there is a touch in this area. What happens, that touch will cause obviously staining at the end of the day. Now, there are 2 ways you do this. You can order a larger diameter lens because the larger a scleral lens or the larger any contact lens, you make the center height higher. Now, when you fit higher, you're obviously able to vault that area of the cornea. However, you might like defeat in other areas, and it's just that particular area that you want to adjust. You can do that with by adjusting the peripheral zone, the paracentral zone rather. Now, all you have to do is specify to the lab whether you want P+1 or P+2. This is adjustable in 50 microns, and it keeps going higher and higher. Or you could switch from a small diameter scleral lens to a larger diameter scleral lens. As you can see in this image, the small diameter scleral lens is touching obviously here, but the same cornea, but a larger diameter lens, and you see that it's vault that area and it's no longer touching. But when you do things like that, you always want to remember that you have increased the fluid reservoir thickness. You do not want to vault one area and make it excessive in another area. If you have that, you can always adjust. Same thing with the limbal area. You do not want it to be compressed on the limbus, because if you do, you could damage the limbal epithelial stem cells, or you could damage the tight junctions. Studies actually show that you may not directly damage the limbal epithelial stem cells, but you could damage the tight junctions between them, cause limbal edema, neovascularization, contact lens discomfort, and at the end of the day, the patient may not benefit from a fantastic medical device that they would have benefited from at the end of the day. I'll just zoom this in. Okay. Now, if the lens is bearing on the limbus, that's pretty easy to see as well, because you see here we have this nice diffuse fluorescence in the center, which means touching. But at the limbal area, we see that there is no fluorescence there, so it is bearing. So what you do is either you're going to fit larger, or you fit by adjusting the limbal zone, and you do this in 50 microns, and you would have lens not touching that area. So if you see this image, we go from bearing, and then you have no bearing just by increasing the lens diameter. Also, you do not want to cause excessive limbal clearance. While there's a risk of, or there's a problem when the lens is touching the limbus, you can also create a problem if you have excessive limbal clearance, because then it creates a hypoxic environment. Edema occurs, neovascularization, keratitis, midday fogging, and a lot of things. You could just simply adjust the limbal zone with the biosafety lens, and you have a good-to-go lens. Now, the use about biosafety lenses, you could actually see the professionalism and the engineering that goes into the lens. You could see how smooth and how quality the lens is, and how the lens is adjust from one zone to the other, independent of what's going on in the area. And usually you will have the patient's vision improve dramatically, usually when you see clear lens is very good. If you see this image, you see at no point it's touching the cornea. This is done without fluorescence, but you can still see that there is no touch. But when you have a touch in any area, you just note that area and you can make the adjustment. Now let's go to the landing zone where the lens actually sits. Now, this is something I usually would say to my maybe interns or people I'm teaching to fit scleral lenses. Use the blood vessels that sits on the conjunctival surface as a ruler to tell you whether the lens is sitting well at the edge or whether it's not sitting well at the edge. Now, if you have the blood vessels being cut off, that means you fit a lens that's too tight. For example, like I said, this is an ideal fit. If we use the blood vessels as a marker, we see that there's no cut in blood supply to the blood vessels on the conjunctiva in the landing zone of the lens, or the scleral zone of the lens. But if you see this image here, where you have the lens sitting too tight, the blood vessels have been cut off, or the blood supply has been cut off. Now, if you do this at the end of the day, or you prescribe this lens at the end of the day, when the patient takes out that lens, it will be really, really uncomfortable. But sometimes even while the lens is on the eye, they may complain of pain. Remember, clear lenses are supposed to be as comfortable, if not more comfortable than soft contact lenses. But when you're not getting that, look for where the problem is. Now, we would describe this as blanching. So you see blood vessels, blood supply here, blanching of the blood vessels, and blood supply here. Now, if the edge is too flat, you would see a standoff. So if the lens is supposed to be aligned to the ocular surface, you would see that it's something like that. And you would see this space as you see here in this image there. Now, that can cause awareness of the edge of the lens as the patient blinks, and they will not be comfortable. Now, this is the lens at the edge that's really, really flat, superiorly. But we see that at the temporal portion, it's sitting tight. Now, this is a tricky case. So obviously this sclera is not uniform. It's not spherical. It's uneven. It's toric. So what that means is it's flat on one area and it's too tight on the other area. Now, biosafety lens still has you covered. We can fit a toric peripheral scleral lens that will align with the zone of the lens. Here, because it's too loose, we can increase the angle of the lens, move it away from the ocular surface. Now, in this area where the lens is too loose, we can bring it in and make it sit properly. So if we were going to change in, say, 25 micron step, we would change this by about 100 microns, and we're changing this by about, say, 150 microns. Now, what this will do is give you a well-centered lens that will not up or will not flex, sorry. There will be no air bubbles because air bubbles can come from this place. There will be no localized area of pressing or compression of the blood vessels. There will be no conjunctival collapse because sometimes if the space between the lens on the limbar area is too high, you could have conjunctival tissue prolapse underneath the lens, and that could be uncomfortable for the patient. And obviously, when you toric peripheral lens, when it's indicated, you could have better comfort and better visual quality. Now, remember at the beginning, I talked about showing you a trick on how to assess whether you maybe need a toric peripheral scleral lens for a patient. It doesn't mean you need this for all scleral lenses that fit, but sometimes you may need it, especially when after fitting the lens, everything looks perfect, but then you start to see this kind of small bubbles trickling down. You know that you may need, the lens might be, there might be a space somewhere. So what you do is place the lens on the eyes, stain it with fluorescein, switch to your cobalt blue, and you would just see fluorescein bleeding into the fluid reservoir thickness. As soon as you see that, you mark areas where you have that bleeding or the fluorescein coming in, and for any other areas where there may be compression on the ocular surface, and you switch to a toric peripheral scleral lens, and that would address that issue. Now, if you look at this image, now this is a lens that looks great and it's been fit, but you see those small bubbles coming from up there. This is obviously an indication that you're having a standoff at some point of the lens. The sclera is toric in this case. And if you even see the lens is moving, you have debris accumulating under it. What you want to do is switch to a toric peripheral scleral lens, and you have problems like this addressed. Now, once you have fit a lens that's well-centered, you have the fluid reservoir thickness after the lens has settled between 100 to 250 microns. The lens is vaulting over the limbus, not excessively and not touching the limbus. It's sitting on the scleral profile very nicely, not blanching any blood vessels. The next step will be to perform an over-refraction. Now, the way you do this is we often would start off with a spherical over-refraction because when you fit a scleral lens properly, most times it eliminates the corneal astigmatism and the aberrations coming from the anterior cornea. Now, that allows you to perform a simple spherical over-refraction. I mean, you would see cases where patients come in with keratoconus and you have cylinders of -12, -13 cylinders, and you fit a scleral lens and you have a spherical over-refraction. All that cylinder, all that irregularity disappears because that fluid reservoir causes to become a smooth, regular surface at the end of the day. Now, you can always adjust the refractive error, your over-refraction over the lens. But the main thing you should keep in mind is fit the lens and do a spherical over-refraction first. You can always adjust the final power, but remember to do a vertex correction because your over-refraction obviously is done with a spectacle trial frame over it or a phoropter, like in this case. But there is that distance between the lens and the cornea, so you want to do a vertex correction. So you remember to do that and add that power to your final order. And then if you have to do any adjustments to the lens, maybe you look at the lens and you're okay with the fit, but maybe you feel I could just increase by maybe 100 microns. You have to adjust the power. So if you're increasing the sagittal height by 100 microns, your final refraction power removes -0.75 from it if you're fitting the 15.1 mm lens. If you're using the larger diameter lens, the larger 16.3 lens, adjust it by 0.5. So increase sagittal height, you subtract minus. If you're decreasing the sagittal height, you're adding plus. So it's sort of like the SAM rule that we use when we fit RGPs. If you're going steeper or if you're increasing the sagittal height, you're adding minus. If you're going flat, decreasing the sagittal height, you're going adding plus. So you might remember Sam Fab from contact lens fitting days in university. If you do have an over refraction that has cylinder in it, and that cylinder is above 1 diameter, and that cylinder is improving vision, you can consider a front surface toric lens. Now, a front surface toric lens, obviously you would need to put, or you would need to fit a scleral, a toric periphery lens, so that the lens is not moving as the patient blinks. So you have a very stable lens. And then that extra toric power is put in the front of the contact lens. Now, as the patient blinks, if you notice maybe adjustments or the orientation of the lens changes and settles at a particular point, you can always apply the last rule. If it goes to the left, you add. If it goes to the right, you subtract. So simple last rule. Now, the biosafety scleral lens would always come with an axis marker for you to know what you're doing and to make the appropriate adjustments. Now, I have seen some patients say, oh, my patient would be a good candidate for maybe specialty contact lenses or scleral lenses, but he has pinguecule or he has pterygium. You could actually still fit the lenses by creating a notch over the lens. So first, what you want to do is, I mean, this would have been what the full lens should be. But if you see here, this has been notched out. This has been cut off. Now, what you do is you measure the depth, the area that you want to notch off. You measure the width into the lens, and you look at the orientation of the axis mark, because you would have to fit a toric periphery lens so that it's sitting well on the ocular surface and not rotating. Once you're sure the axis mark or the rotation mark is stable and it's not rotating, you could take your marker and just mark the areas that you want to adjust, or you could use your slit lamp, reduce the height of the beam, and measure the areas that you want to be notched out of the lens, and Bios Lens Lab will do the rest for you and send you a lens that will fit perfect on your patient's eye. Now, sometimes you fit a toric lens and you may want to know, okay, have a lens that maybe when the patient blinks will rotate. What you do is you want to nudge the lens a little bit and let the patient blink and see if the lens goes back to the original position where it was before. Lens does that, goes back to its original position. It means the amount of toricity that you have added to the lens is adequate. Now, like I said, this is the first of a series of presentations. In subsequent presentations, we'll be looking at advanced here you can see that this rotation mark. So you see that the rotation mark where it was before at the beginning, before the practitioner rotated the lens, and you watch and see as the patient blinks, and you see that the lens goes back to its original position. As the presentation goes on, if you have questions, please put them in the comment section. I'll be taking the questions after. So you see the lens has gone back to its original position. So that shows you that the toricity that you have added is great. Like I said at the beginning, the biosafety scleral lenses can be coated with Hydra PEG. So that's Hydra polyethylene glycol. So it creates this smooth, slippery surface over the lens so that you do not have deposits attaching to the surface of the lens. So I'll just recap what we said at the beginning. You want to take a careful, good history, know why you're fitting this patient, do a very careful slit lamp biomicroscopy examination. You select your lens based on maybe your topography, or biometry, or scleral topography, if you have that. Do a refraction so you just have an overview of what to expect. You choose a lens, place that lens on the eyes, check for the fitting and the centration of the lens, evaluate the lens central part and the limbal area just to make sure that you are fitting a lens that's not having excessive clearance, or both at the central part and the limbal area. Wait for that lens to settle for about 2 hours. Now, after that lens has settled for about 2 hours, check all 4 quadrants, superior, inferior, nasal, and temporal, and make sure that that lens is sitting nicely on the ocular surface without blanching or without standing off. Do your refraction. What's very, very important. I mean, this is something that I like to ring as a bell. Every scleral lens fitting should start with the lens on the eyes, would always end with the lens out of the eye so that you see what happens to the ocular surface, because this is where you can actually pick complications. Now, I've put different images here. Now, in the first image, we have midday fogging because of excessive clearance. You see this? Decrease the fluid reservoir thickness. You could also have limbal redness. Now, this may be because the lens is compressing at the limbal area. You might want to change the landing zone, the limb zone of this lens. If you see compression like this, especially at the center, you see these punctate stains around the central part, especially when you have like a nipple cone or a proud cone, it means you fit it that the fluid reservoir is too little and it's compressing the cornea. And in subsequent webinars, we will also be looking at complications that can occur with scleral lens and how to address them. Now, remember I talked about when you fit a lens too tight. In this first image, you see after taking off the lens, which is very important, examine and you stain with fluorescence, we see that there is an impression ring here. Also, if you see this image, you see blanching. So when you take off a lens that's blanched, you would like an indentation ring. Now, sometimes you have a patient who you put this clear lens, vision improves, everything looks great, but the patient keeps telling you, I get this pinchy feeling somewhere. Check very well. You might have an edge lift, like you see in this image. Now, again, these are my emails. You can reach me on any of these. I'll be very happy to answer your questions. I'll be very happy to help you order lenses. So you can reach out if you want to get trial sets, or you want to discuss keratoconus management with specialty contact lenses in general. Biosafety lenses have a full range of lenses that can actually offer your patients good vision and comfort at the end of the day. So thank you everybody for joining the webinars. I'm going to give room now for questions. You could leave them in the chat section and I'll just take the questions. So just type your questions if you have any, and I'll be happy to take them. Thank you very much, everyone.
Hello, Dr. Meta, can you hear me? Hi. Good evening.
Good evening, I can hear you.
Okay, it's Dr. Peace. It's
Hi,
actually a
Dr.
nice lecture. I've been with you since you started, and honestly, I gained a lot. But then there's something I want clarification when you're talking about the use of the scleral contact. You're talking about it serving as a kind of a bandage for the scleral laceration. Yes.
I can barely hear you, Dr. Peace, if you can. But I got the part where you said about scleral lens serving as a bandage.
Yes. So serving as a bandage, when you're talking about the usage, I was just wondering, since the scleral lenses from your explanation or from what we know also, it shouldn't sit on directly on the cornea, yeah? Now, what the bandage does is to sit on the cornea to help, like serving as an adjunct to help seal up or to help cover up the tear. So if scleral contact lens doesn't sit directly on the cornea, then how does it work? How does it work as an option for bandage,
Okay.
like to just help?
All right, so thank you very much for the question. I mean, that's something that I used to wonder at the beginning too. Now, here's the thing. Let me paint a picture for you. When you fit, let's say you have a patient who has maybe corneal abrasion, for example, and you could fit a soft bandage contact lens on that, no issues. The thing is, when you fit a bandage contact lens, it sits directly on the cornea. It still moves a little bit, so it allows tears and all that to go underneath it. But with a scleral lens, it's sitting over the cornea, not touching the cornea, because that mechanical interaction from soft bandage contact lens in some cases may still be problematic. If you've seen patients who have this persistent epithelial defect, that's an epithelial defect not due to microbial keratitis that has been there for above 2 weeks despite using bandage contact lenses, artificial tears or gels, padding the eyes and all that, you could have that persistent epithelial defect still there. And that's because the lens or whatever treatment you're using is still making contact with the ocular surface. So the stem cells from the limbus that are trying to migrate towards the epithelial area that's been affected are not able to migrate due to mechanical interaction. When you fit a scleral lens on the eyes, because of that no touch, and keep in mind, it creates this hydrated environment underneath it, which allows epithelial cells to grow. So there is no contact from your eyelid. There is no mechanical interaction like your standard bandage contact lens will still have because it's sitting directly on the cornea and can still be moved by the eyelid on the scleral lens. And what's more interesting is you could put preservative-free medications. So when you fill the scleral lens with your saline, when you put preservative-free medications there, it could act as a drug delivery system for allowing the lens to keep medications against the area where it's needed. I mean, there are studies that actually show using the scleral lens, aside from maybe patients with persistent epithelial defects or exposure keratopathy, there are studies that show you could use it as a drug delivery system for other corneal conditions, including corneal neovascularization. There's a study that was published in Contact Lens and Anterior Eye, where they had taken anti-VEGF medications, your Avastin or your ranibizumab or bevacizumab, and you put that in the fluid reservoir and you put that against the cornea, and it's been shown to actually decrease corneal neovascularization. So aside from the preventing interaction from the leads, no mechanical interaction like your standard bandage contact lens have, you could use it as a drug delivery system and create an ecosystem where you encourage epithelial cells to grow and thrive, and that helps with the healing of the cornea. And it's very important when you use it for ocular surface disease or like severe dry eyes or Steven-Johnson syndrome or what have you. So I have other questions. So I will start. So if you have any questions or contributions, just keep it coming. I would try and go through as much as possible. Okay. All right, so someone says, can we get the material for clear understanding? Yes, it will be available and it will be emailed to you. The link will be emailed to you after the presentation. Can you drop your email address in the chat? I will do just that now, and feel free to contact me and we can discuss if you have any questions or contributions. So I'll drop 2 of my emails. You can email me on any of these.
Hello, boss. Hello, boss.
Someone saying something? Okay. Okay, I've dropped my email address. Does BioLens have a digital brochure? Yes, BioLens does have a digital brochure, and that will be shared together with the email package you will receive. Are there parameters you have to compensate for when you adjust the fitting by increasing the vault? Yeah, like I said, when you increase the vault, if you're using maybe the small 15.1 diameter lens, if you increase the sagittal height of the lens by say 100 microns, you would have to remove -0.75 diopters from your final over refraction on the lens. Same thing if you're decreasing the vault as well, because you need to keep in mind there is this fitting relationship between your base curve as you adjust it, or the sagittal height as you adjust it, and the final power of the lens. Again, if we go back to the lecture, if you look at the recording, it's explained there. But if you still need more clarification, just email me. I'm happy to communicate that to you. A Cornea RGP is available for BioLens. Yes, Cornea RGPs are available, and that will be the next presentation that we're looking at. How to actually fit these lenses, Cornea RGP lenses, because BioLens has both scleral lenses, orthokeratology lenses, corneal GP lenses, soft contact lenses, cosmetic lenses, toric lenses, multifocal lenses, prosthetic lenses, everything actually. pediatric contact lenses and all that, even bandage, soft bandage contact lenses. I see some people dropping your emails. Don't worry, so long as you registered for the presentation, you'll get an email once the recording is made available. And the brochure of violence will be sent to you. Someone asked, thank you, great presentation, thank you so much. How can we get lenses in Kenya? Just shoot me an email. Again, my email will be at the end of the presentation, and it will also be in the email that you sent. We're actually working on a series of trainings. There's going to be the online series, and the next part will be going across different parts of Africa, West Africa, East Africa, teaching people physically how to actually fit these lenses. So there's going to be a physical workshop that would occur throughout the course of this year. That's the plan. Yes, the recording will be shared along with the brochure. Thank you everyone for the kind words. Yes, the materials will be available. Yes, the recording will be available. Yes, like Obi said, just stay tuned to the iAfrica Media platform. The recordings will be sent once it's available on the YouTube channel. Yeah, thank you everyone. Thank you so much. Thank you. Thank you. Okay, so you couldn't hear the promo videos. Those would also, a link to the promo video would actually be sent to you so that you can actually look through the videos. Thank you so much. All right, thank you everyone. Yeah, thank you, Chinelo. That's a very kind thing to say. All right, thank you everyone. I'm very glad you all could join in. I'll try not to take too much of your evening. Like I said, there'll be other series where we'll be looking at RP contact lenses, fitting orthokeratology lenses, fitting other forms of contact lenses, even prosthetic contact lenses. And after the online series, the next step would be to go to different countries and actually teach physical fitting or do workshops on how to fit these lenses. Again, thank you all for joining in. I think we can end the presentation, the lecture here now. If there's no other question. Thank you so much. Enjoy the rest of your evening. Thank you all for joining.